Hi, I'm Sanjay Mujumna. I'm a plastics and hand surgery consultant from Yorkshire in the United Kingdom. Today we're going to discuss carpal tunnel syndrome, which is quite a common thing amongst our population. Now, what is carpal tunnel syndrome? Carpal tunnel syndrome is a medical condition where people complain of tingling and numbness and clumsiness in their hand, and this is due to compression of the median nerve within the wrist, or the carpus. That's why the term carpal tunnel syndrome. So we will discuss the anatomy of that in a second, but let's first start with who gets it. Well, most people who have carpal tunnel syndrome have no predisposing conditions. However, it's known to be more common in women of middle age, whatever middle age is, people with diabetes, hypothyroidism, pregnancy, rheumatoid arthritis. Now, interestingly, for diabetes and hypothyroidism, this may be how people actually present with those conditions. So it is recommended, as a person doesn't have diabetes or hypothyroidism, it may be good to screen them for it if they just present with carpal tunnel. That's an aside. Now, what are the symptoms of carpal tunnel? What does the patient present with? The patient will come to you and say, "Doctor, I've got tingling and numbness in my fingers," and that is classically in the thumb, index, middle, and a little bit of the ring finger, which is where the median nerve actually supplies. But patients may say they have these symptoms in all the fingers, may be associated with discomfort, which may be radiating up onto the elbow, onto the shoulder. They also complain of clumsiness. They say they drop things like coins or crockery or cutlery or mobile phones. The symptoms are often brought on at night, it wakes people up, or it may be, the onset may be in the morning, so people wake up with the symptoms, or people find that they have symptoms when they're doing certain tasks, all of which involve grasping, such as using a mobile phone, reading a newspaper or a book, driving, or using a tablet, using cutlery and such like. A lot of patients will tell you that when they get the symptoms, especially at night, they try to do this movement, which is called the flick test, which is they are trying to get blood back into the hand. It's known to be quite pathognomic for people with carpal tunnel syndrome. When a person comes to you complaining of these sort of things, you've got to take a history of any possible neck injuries or neck problems, such as neck pain, because people could have neck issues which may give you the same sort of symptoms as carpal tunnel syndrome. So now we've got an idea of who gets it and what it is. Let's look at the anatomy, because that'll give us a good idea of what's actually happening and what tests we do to diagnose it. The carpal tunnel is, let's take our friendly skeletal hand here, is a tunnel made up of the carpal bones, which form, as you can see here, a concave shape, and on top of that there's a little band which is called the flexor retinaculum, and this band goes from one border to the other, and it essentially forms an unyielding tunnel which is made up of bone and is unyielding flexor retinaculum. Now, it's important that this is at the wrist, because a lot of people think the wrist is this part of our forearm, the distal forearm. The wrist is actually here. If you put your finger here and here, you can feel the end of your radius and ulna, and the wrist goes from the distal wrist crease here, okay, to about 2 to 3 finger breadths going on onto the palm of the hand. That is where the wrist bones are, and that's where the carpal tunnel is. The importance of that is, if you think the wrist is a bit proximal and you're putting injections of steroid also to treat it, you're putting it in the wrong place and it won't work. So you've got this carpal tunnel, and that through that carpal tunnel goes 9 tendons. So those are the flexor tendons that are going into the fingers and thumb to allow you to bend the fingers and thumb. And also through that is the median nerve, which supplies innervation, or sensation rather, to thumb, index, middle, and half of the ring finger classically. So you could see this carpal tunnel, not very big, and through there travel 10 structures. So you can imagine it's quite tight in there, and anything that increases the volume of the structures or decreases the volume of the tunnel will cause squashing of the nerve. Now, it's not a direct squashing of the nerve, but it is actually compression or squashing of the thin blood vessels that lie on top of the nerve. And when you squash it, you essentially get ischemia. And when nerves get ischemia, you get tingling and numbness or weakness. So that's the carpal tunnel, and that's why you get carpal tunnel syndrome. So this can explain to us now why people get symptoms. The symptoms and when they get it is they get it at night, because when they go to bed and they lie down, all the blood that is in their lower limbs gets redistributed and can go into their hands because they're lying horizontally. It's a bit like, why do people get heart failure at night? Because all the venous pooling of blood then comes back up and it overwhelms the heart and they get heart failure. Similar sort of reason, redistribution of blood. The other thing people do at night is that they sleep in this fashion. So they flex their wrists in. So they get into the embryonic position, and that position has been shown to increase the pressure within the tunnel, and thus they get symptoms. Now, why do people get symptoms when they're holding a mobile phone or holding cutlery or driving? Well, what happens is that when people are grasping, we are flexing or bending our fingers, and for us to do that, the muscles in our forearm contract and the flexor tendons are pulled in so that our fingers go into a flexed position. And when that happens, the bits of the flexor tendons that are initially outside or distal to the carpal tunnel are brought in under the carpal tunnel. This in itself is not a problem because the tendons actually get narrower as they go more distally. However, just beyond the carpal tunnel, just beyond this level, from each of the flexor digitorum profundus tendons arises a muscle called the lumbrical. So there are 4 lumbrical muscles. So when you do that, the lumbrical muscles, which normally live just outside the carpal tunnel, now slip in under the carpal tunnel, within the carpal tunnel rather, so under the flexor retinaculum. So now you've got 9 tendons, a nerve, and 4 muscles instead of just 9 tendons and a nerve. And these muscles obviously get a bit more blood supply because they are now working, so they get a bit fatter. So you've got a lot of crowding in there, and if a nerve is sensitive to overcrowding, like someone with carpal tunnel syndrome, the symptoms start off. So that's why we get symptoms of carpal tunnel when we are grasping a mobile phone or reading a newspaper, etc. And this is much worse when our hands are up in the air because you have a less blood pressure inside your hand, and that would explain why people get this doing those tasks. Right? When you finish taking the history of from the patient, the symptoms in the vast majority of times will tell you whether the patient's got carpal tunnel or not. But you've got to obviously examine the patient, and this will give you extra information that may give you the diagnosis in most of the other times. Now, when you examine the patient, you've got to rule out neck pathology, so you do have to examine the neck, and you do have to examine the forearm to make sure that the median nerve, which can get compressed between the 2 heads of pronator teres, isn't being compressed there. But focusing on the examination of the hand for someone with possible carpal tunnel, you obviously have to look at the sensory element of the median nerve as well as the motor element of the median nerve. Now, if they've got sensory changes, it'll be tingling and numbness or paresthesia, thumb, index, middle, and radial half of ring finger. You've got to understand that most people don't have that because most people's symptoms in carpal tunnel that present are transient. So unless you have someone who has symptoms of paresthesia all the time, you may not pick up any difference in the sensibility. You also have to look at the motor function of the median nerve, because the median nerve, as it comes under the carpal tunnel, then gives off a branch to the muscles in the thenar eminence. And you have to examine for the abductor, abductor pollicis brevis, which makes the thumb abduct, which is move the thumb at a plane 90 degrees to the plane of the palm. And you do that by asking the patient to abduct the thumb against resistance. So you put your finger there and say, can you push my finger away please? And when they do that, you can feel for the abductor pollicis brevis muscle and see if it's actually tightening up and how much force they have. So you check for weakness of the abductor pollicis brevis as the motor sign. Again, this is something that's quite uncommon unless your carpal tunnel is quite severe, has been there for quite a long while. There are provocative tests that are quite important. The provocative tests that are traditionally done are Tinel's, which is essentially tapping over the carpal tunnel to see whether a patient complains of tingling and numbness or electric shock type pains going into their fingers. Start distal to the carpal tunnel and then go on to the carpal tunnel itself. This was described by Jules Tinel. This is only 50% sensitive. The next test is Phelan's, which is flexing the wrist for 60 seconds. And Jules Tinel said, George Phelan in his paper described holding the hand, forearm vertically and letting the hand drop for about 60 seconds. Now, this is about 68% sensitive. So there is another test called the Durkin test, which is essentially compressing the carpal tunnel with your thumb, and that again is about 64% sensitive. Interestingly, if you combine the Phelan's with Durkin's, which is compressing as well as flexing, not over flexing, just gently flexing at the wrist, that increases the sensitivity of the provocative test to 80% and is 92% specific. So quite sensitive and quite specific. And I would suggest that's the way to do it. Some people do a reverse Phelan's, which is instead of this, they do this, which is like the namaste sign. That again is not hugely sensitive nor specific. Neurophysiology, a lot of people think plays an important part in carpal tunnel syndrome diagnosis. The evidence is not so. The combination of nerve conduction studies and electromyography, which is neurophysiology in combination, is only about 54% sensitive, but it is importantly 94% specific. So it's good to use that to rule out other things that may mimic carpal tunnel syndrome, but it may miss carpal tunnel syndrome, especially in the mild cases. Important to remember that. The treatment for carpal tunnel syndrome, splints may help, especially for people who are having nighttime problems when they're flexing their wrists. Steroids, again, are important for diagnostic if you're not exactly sure what's going on, but may be helpful in people who can't have an operation or may have temporary carpal tunnel syndrome, like people who, ladies who are pregnant or people who are not fit for surgery. But the definitive management for carpal tunnel syndrome is carpal tunnel decompression. It's an operation where you make a cut there and essentially release the flexor retinaculum, that strap which is sitting on top of the carpal tunnel, the roof of the carpal tunnel, so to speak. This can be done either as an open procedure, which is the common thing, numbing this area with local anesthetic, making a cut, going down, releasing it, and then stitching back the skin, or it can be done endoscopically, where you take an endoscope and introduce it into just proximal to the wrist crease and approach and release the flexor retinaculum from the deep surface. It's important to tell the patient it may take up to 3 months for full recovery in terms of hand function, because you can get discomfort. It's quite an important part of the hand. The relief may be complete in most times, but can be incomplete if there's been injury to the nerve, which is irreversible, or sometimes you can have recurrence. And the final thing to say is that if one does not get full relief or there's recurrence, you've got to think, is there compression of the nerve elsewhere, in addition or separate from the carpal tunnel? Remember double crush, where you could have the nerve being squashed in the carpal tunnel, but also in the forearm or in the neck, and there neurophysiology can be helpful. So that is carpal tunnel syndrome in a nutshell.